Excuse me, doctor.
Yes.
I am new.
Okay. Where are you from? You're from Colombo, or is it something? Are you from?
I'm from Vattala.
All right. Okay. Anyone else who's new?
Excuse me, doctor, I am new too.
Okay. Right. How many? So then there is a total of. I'm assuming two. Anyone
Yeah.
else?
Hello.
US person.
Yeah. So we've got around three or four. Right. Don't worry about it. Okay, guys. Don't worry
Hello.
about it at all.
Hello. I'm
Right.
new as well.
All right. Okay. Don't worry about it at all. It's just that for my information, to know if by any chance, when I'm actually explaining, I need to understand that there are people who don't actually who have not been for the here for the class. So therefore, that is the only reason. All right. Okay. So we've done two classes on this, right? We've started. We've started. Can you all see the screen?
Yes, doctor.
All right. Okay. Right. So the first we spoke about the principles of first aid, right? We spoke about why first aid is important, the number that you call if by any chance you are you're in an area where there is something that is wrong and you need help. You need to remember this number. It is 1990 or 1990. Uh, you have to tell where you are based on your address on the proximity towards the police station. So for example, if you are in Vattala and the nearest police station is obviously the Vattala police station, so you actually tell them according to where you are based on the nearest police station. And I think it's one of the greatest things that is there in the health sector in Sri Lanka, which has helped in saving a lot of lives. The next aspect is getting doctors in these ambulances, because right now there are no doctors in these ambulances, it's just paramedics, right? Uh, so there is there was a part of the survival chain, right? I think I have given you all assignments, right? I gave you all some questions that you all need to actually answer. uh I don't know. Like in a sense, I will send you my email address. Please send it to me so that I will actually discuss that next week, because I don't want to actually discuss it today because there are a lot of students who won't be coming for today's class because of Christmas and all the other lecturers have actually kind of given holidays. But I didn't want to do that. I just wanted to actually continue this because there was a momentum going on. So let's discuss those questions next week. For now, let's discuss some important new topics, right? Because that's what's important. Right. So our first scenario was when you're driving right on in the highway, and you and your friend notice there's a car toppled on the other side with a man outside. Right. So this was something that I asked y'all what we would do, and our response was that a lot of you all said that I will stop the car and go and see how he or she can help. But you have to understand that you have to think on your feet. On a highway, can you move on the other side? No. So the only best help that you can give is call the relevant authority. So call 1990, call the relevant authority. There is a car toppled on the ground on the other side in this area. That's it. Nothing else. Nothing else can be done. Nothing else should be done. Because what's the most important thing? You need to make sure, according to your algorithm, it is what? DR, as everyone forgot.
DRABC.
Very good. So what is D? D is danger. So you need to make sure that you are safe, right? You are safe, and then you need to make sure, right, that the patient is also safe. So first you need to ensure that your safety is checked. The second is you need to ensure the patient's safety, right? So because of that you can't, right? And the next thing that you can do, I mean, if you were on the same side, right, then you could actually stop your car, right? Make sure if the patient is in the middle of the road, you can slowly bring him. Make very careful, very important, because transporting patients is also very dangerous, right? So I don't recommend it unless you have a spinal board and You need to do something called a log roll, where you slowly turn, because sometimes what happens is, I didn't discuss this, sometimes there can be cervical spine fractures, that is, your vertebral fractures. So when you move, pelvic fractures, when you move, what happens is the fracture is not like, in a sense, there is not a lot of basically it has there is a fracture, but it has not moved. So if by any chance, by moving the patient, there is a possibility that you can dislodge the fracture fragments even more. And by doing that, especially if it is a vertebral fracture, you can damage the spinal cord. What will that result in? Paralysis, right? Obviously not the hemiparalysis, depending on the location of where exactly the fracture is, right? So this is a dangerous complication while transporting patients. That is why when you see someone on the road like this, why do I tell you all to call 1990 rather than just get a tuk driver and bring him to the hospital? Right? Sometimes the tuk driver, if the tuk driver is there, you can bring the patient directly to the hospital as soon as possible. But the problem is what? While moving the patient, while making him sit in the auto, or while putting him in an uncomfortable position in the auto rickshaw, what's going to happen? If he's got some kind of vertebral fracture, it's going to result in what? He's absolutely fine, right? His fracture is not dislodged so much that it has damaged the spinal cord. But by moving that patient, you're going to cause a permanent paralysis that cannot be fixed, right? So this is why we tell that it has to be done by people who understand this, right? So that is that, right? So again, you have made sure that you're safe. You can slowly move the patient as to make sure the patient is safe. Then you check for response. How do you check for response? Right? Responses, you check if the patient is what? Like a lot of you all said, how do I know if this patient is alive? By actually, some people say check if he's breathing, check if he's got a pulse. No. How do you normally check if someone is alive? I mean, just talk to him, like in a sense, just shrug him on the shoulders or shrug him on the breastbone, right? That is the sternum, and see if by any chance the guy is actually talking or saying anything or making weird noises. Because if he's talking and saying, I have a lot of pain, which means obviously if he's talking, his Yahweh and breathing and circulation, which is ABC, is absolutely intact. Because if he's talking, it means his Yahweh is clear. If he's talking, it means he's breathing. Obviously, you cannot breathe and talk. No, obviously you if you're talking, you're breathing. And obviously, if you're talking, there has to be a pulse. Pulse is like a way to show when the heart is beating. Obviously, unless you're from this, as I told you, if you're if the patient is a zombie, I'm sure that definitely the patient will have a pulse. But in the case that the patient doesn't talk, the patient is not responsive, then yes, then you need to go into Yahweh breathing and circulation, right? So let's look into that, right? So this is how you check for response, right? You can see shrugging the shoulders, like, hello mister, are you okay? Hello sir, are you okay? Hello madam, are you okay? Can you hear me? Right? So that is this thing. And then if by any chance he isn't, you can call for help, right? So that is why DRC, call for help. So some people can do some people can do danger, call for help, response. Some people will do call for help, danger, response, and then ABC. Right? Sometimes when you actually wake the person up, he's like, I'm absolutely all right, just fainted. And then you can leisurely take him to the hospital, right? So that is also there, but it all depends. It doesn't matter, but very important. If you feel that this patient, I think for your level, remember calling for help is always important. The reason I tell why calling for help early is important is because you don't have to tell everything what is going on. Just say that there is an accident, right? So let's just say that you saw this at 7:44, right? You called for help at 7:45 a.m., right? Now you had to turn your car. You went and stopped the car at 7:47 ago. Then afterwards you went to the patient. You kind of saw what exactly you moved the patient or whatever. It's already 7:54, 7:55, and that's when you're trying to check for response and he's not responding. Just imagine that you calling at 7:55, right? It's going to take another 5-10 minutes for the ambulance to come. But sometimes when you're checking the response at that time, if you have called early, the 1990 ambulance service has already been there. It's like, okay, Mate, I will take over from you. You get what I'm trying to say? So that is how important it is. What I'm trying to emphasize is how important time is, right? Time is of essence, right? And that time, little bit of time can change that person's life. Not just change that person's life, can result in death or life, right? That's how important it is. A little bit of time can decide if your heart has beaten more or less, or heart has not been beating for this significant amount of time. Starting early CPR can complete. We discussed that. Let me go into that. Right. So the what is Yahweh? You check if the Yahweh is patent. If there is any foreign bodies that are obstructing, you have to remove. If there is vomit, if there is foreign bodies, you can take your finger and slowly remove it. If there is vomitus, also you can actually slowly try to remove it. Right. If there is anything, there is something called a Heimlich maneuver and all, which I'm not going to tell you all about. Right. So there is another way that we can make sure that the Yahweh patency. What is it called? Chin lift, head tilt, jaw thrust. So you lift the chin up, right? You tilt the head and you open the mouth with the jaw thrust, right? So you can see the chin lift, the head tilt, and the jaw thrust, right? So this is a triple maneuver for making sure that to see if the Yahweh is patent. What do I mean by to check if the Yahweh is patent? Anyone? Can someone tell me?
Like to check if there's something obstructing the airway, like to find out if there's a smooth flow of the air.
Yeah, that's good. Okay. Smooth flow of the air. So where does the air go to?
Lung.
Goes to the lungs. Okay. I think doesn't work without my pen. Hold on. Yeah, so it goes to the lungs, right? So I was trying to draw and show you all. Hold on. Okay. How come I can't draw this? Right. Can you see this? Right. Okay. All right. Right. So we've got rough this thing, right? And you get the heart here, just the rough this thing. So this is the trachea, correct? This is the right bronchus, left bronchus. So what we try to do is this, there is obviously from the face, right? Yeah is coming from the face, yeah is actually coming inwards, right? Sometimes there can be a blockage, right? So that is what we try to do by preventing, not at this level, but from the head, right? From this level, right? When you have this person's face, right? By checking if this area is there anything that is blocking either from the nose or from the mouth, is there anything that is blocking the pathway of the airway, right? So you know what is the pathway? The air will leave the nose and then go into the nasopharynx, right? The oropharynx, then the trachea, bronchus, and the lungs, right? So that is the pathway. To make sure that that pathway is not blocked, that is why you need to make sure you can preserve the air. So this area, if you want to increase the patency, now usually when you're talking and all, right, you can see from the nasopharynx, right? if this is the nasopharynx, this is like, imagine this is the mouth in out inlet. Okay, that is this is his face, right? This is his mouth. His nose is here. His eyes is here, right? This is how we normally talk. There is not. Let's just say there is only 90% of air that is going in, right? Not percent as in the amount of air. Okay, 90% of air. But when you do the chin lift, jaw thrust, what it will do is it will open up the airway a bit more, right? So it will open it up more. That is what it does, right? It basically helps in allowing more air to enter your lungs. Remember that, right? I didn't discuss that last week, but that is what exactly it is. All right. Right. So basically, you check for the airway, right? You check for the airway. The airway is clear and open. If it is clear and open, you check for breathing. If the breathing is present, you turn the patient in the recovery position, the left lateral position, which I will discuss today. And that's it. And then you try to wake him up. If you can't, wait for the ambulance to come, or you look at whatever else the problem. There are any other problem. But if the airway is blocked, you can actually, again turn him in the recovery position, and then you can actually take off whatever that is obstructing, and then you check for the breathing, right? So if the patient's breathing is absent, right, then that's a different story. But how do you check for breathing? What was the maneuver I told you? What's it called?
Triple airway maneuver.
Yeah, what is it called? It's called, how do you check for the breathing? It's called look, listen, feel, right? How do you know if a person is breathing or not? Now, how do you know if a person is alive? By checking his response, right? If he is actually talking and doing all of that. So breathing is a part of what he needs to do. So how do you check for breathing? Look, listen, feel. How do we look? We look for the chest movement. We put our face, right? We put the side of our chin close to the guy's face, right? So basically, your eyes should be pointing at the chest. Your ears should be more towards listening if you can hear him breathe, and your cheeks should feel the breath from the nose. If all these three are there, right, or if any of them are there, then you know the patient is breathing, right? So kneel down and put your cheek close to their face. Can you feel their breath on your cheek? See their chest moving or hear them breathing? So it's look, listen, feel, right? If the guy is not breathing, you can give them two rescue breaths. How do we do that? We actually pinch the nose, right? And we give two blows, right? We take a good deep breath, right? And we blow into this thing, the airway, right? We blow into the mouth. So that actually helps to, kind of kickstart kickstart the breathing. So that is what we try to do. But on your level, don't try to do this with the current crisis and all. I don't recommend it at all for you, right? Then after breathing, you check for a pulse, right? So there are different pulses, which I actually last time taught you all. I have a separate slide on that, right? So carotid pulse is, you use two fingers. Always remember, for pulses, don't use one finger, use two fingers. So usually your index and the middle finger, and then you feel, like for example, if your carotid pulse, it is in the hollow between the Adam's apple and the sternocleidomastoid muscle on the neck on one side. I'm sure you all can feel it right now. You can feel a throbbing, a pulsation. That is the carotid pulse, right? So if the pulse is absent, if it is absent, then you have to start cardiac massage. So how do you start cardiac massage? You put your dominant hand, place the heel of your dominant hand in the center of the chest and the other hand on the top. So if you're a right-handed person, your right hand should be on the bottom and your left hand should be on the top, right? It should be placed at the center of the chest, more on the left side a bit. You should interlock your fingers, and you need to put pressure from the heel of your hand, not from your fingers, but from the heel. And you need to compress at a rate of 100 to 120. It should actually go around 5 to 6 centimeters deep, right? And you should not, you should give time when you release. because what you're trying to do is you're trying to basically create a scenario, an external way the heart will contract and relax, which is called systole, diastole. You'll allow the heart to go into a systole, you'll allow the heart to go into a diastole. So just pressing, what is it going to do? It's going to be lots of systoles and no diastole. But what is the essence of diastole? In the diastolic phase, what happens? The heart. What is the essence of the diastole? I'm sure, do you all know the words systole and diastole? I'm sure you all should know.
The heart gets filled with blood.
Exactly. So the heart gets filled with blood. So just imagine if there is just systole without diastole, what is the point of doing CPR? There is no blood going around the body. The point is so that during the time when the heart has stopped, you are compressing the heart so that that blood is moving all around the body. But if the heart has not even been filled with the blood, right? There's no point of just squeezing an empty heart. So that is why you need to relax. When you relax, you allow the heart to be filled with the blood. So then afterwards you press, then it goes again, relax, and then heart gets filled with the blood. So this is the importance. So a lot of people I see, medical students and all, sometimes they have not learned the principles. They don't understand as to why they need to relax, right? So remember this, right? And usually if you do good CPR, by 2 minutes you will be very tired, so you need to change, right? But if by any chance, as we discussed, if you come into an instance where uh, you don't have anyone else, you just have to continue, right? So as you can see, you try your level best to be as comfortable as possible, and you give the weight from the fulcrum of your hips, right? So your weight, there was a nice slide discussing this, right? You can see from the fulcrum of the hip joint only you get that weight. So you're getting your body weight also when you're giving the CPR. So you don't, the whole point is so that you don't get tired. You can see the elbow joint is straight. When you keep it straight, again the weight of your body comes into play. So these are all essential because this will allow you to carry out effective CPR for longer duration. That's the whole point, right? So when do you stop CPR? So that is when patient starts breathing, right? If someone actually seniors, someone else who is more experienced will come and take over. An AED, that is an automated external defibrillator, is ready to use if the scene becomes unsafe or you're physically unable to continue, right? So these are some of the reasons as to when you should actually stop. But deciding, okay, it has been more than 30 minutes should be done by a doctor, right? This is what I was telling you in the start. CPR alone, right? CPR saves 400,000 cardiac arrests that happen outside of the hospital. So if a person is fallen on the ground, right, in outside a hospital, 400,000 people are alive because someone outside carried out CPR, right? Hands only, that means without any mouth-to-mouth ventilation, hands only CPR can double or triple an adult patient's chance of survival, right? So you need to understand, in 4 minutes without oxygen to the brain gets permanently damaged, right? So this is the reason, because to prevent the brain from dying off is the reason why we have to start as soon as possible. So if someone passed out or someone went into cardiac arrest, right, and you come in 1 minute, you have increased his chance, right? But if you come after 5 minutes, I don't think it's going to do any good, because sometimes what happens is you can regain the heart, but the brain has already permanently damaged. So it's very important starting it early and starting it as and continue until a person comes over. I mean, an experienced person comes over. So last time I was actually ended the whole class by discussing the pulse points. Where are the pulsars, right? So this is a particular slide I got it off, right? So we discussed the dorsalis pedis. It is over the instep of the foot, or it is more on in between the first and second toe, right? So it is around 2 centimeters from the base of the first and second toe. That is called a dorsalis pedis. Posterior tibial is medial of the medial malleolus. It is medial of the medial malleolus, right? The femoral is near the pelvic bone. Popliteal is behind the knee, right? Carotid is at the side of the neck, which I told you it's between the Adam's apple and the sternocleidomastoid. Temporal, I told you, around 1 to 2 centimeters from, actually 1 centimeter from the tragus of the ear, right? Or it is more on the outside, as in lateral portion of the eye, right? So if you feel, you'll feel a temporal pulse. It's called not temporal, it's superficial temporal. Then you have a brachial pulse, which is the medial side or the inner side of the biceps, and the radial pulse, which I have told you, it is against the thumb. It is in the line of the thumb, and it is the lateral part of the forearm, or you can also call it the on the top of the radius. If you know where the radius bone and the ulnar bone is, it is on top of the radius, right? It is a distal forearm. So these are the pulsars, right, which I wanted you all to know. But the most common pulse that is checked when there is a person who has passed away is carotid pulse, right? Carotid. Right. Any questions so far? Because I'm going to start a new topic. I'm going to start seizures. I want to do that. It's been there for a long time. What do you do? What is a seizure? Does anyone know what a seizure is?
Yes.
Yeah. So it's a fit, right? A seizure is a fit, right? If someone is actually having, he's moving his body, right? With unconsciously, he's moving his body. He sometimes gets froth in his mouth. He sometimes automatically passes urine, right? His eyes get rolled upwards. He sometimes can defecate, right? So that is when you know it is a seizure. So let's just say that you're playing cricket, right? And then you see a person fitting. If you see a person fitting, right, there is what would you do? It's a kid. They were playing cricket. So all of a sudden, he started fitting. Let's hear people out. One by one, if y'all want, y'all can unmute and tell me. Have you ever seen anyone who's have had a fit?
No, doctor.
No,
No,
never.
doctor.
No. Okay. Right. So because there are people, I don't know if y'all, so that means y'all don't. There are people who take drugs to prevent fits. It's called epilepsy. Epilepsy is a condition where it's because of the neurotransmitters, right? So there is a problem with the neurotransmitters, and because of that, they are predisposed in getting fits. If they don't take their medicines, they can get a fit, right? So they need to be on long-term phenytoin or whatever, sodium valproate, whatever a doctor has decided. And if they don't, they can get it. So they have these cards. I'm an epileptic patient. But forget those patients. So you're just generally, let's just say that you're playing cricket with a few of your friends and you find this guy fall on the ground. Now remember, you don't need to know about, I told you, you don't need to know about the seizure, but you need to do basic things. So if this guy is on the ground and he's fitting, what would you do? Would you stop the fitting? Would you hold him like so that he doesn't fit?
I think the same procedure as CPR would be applicable, but then here we might
I
have to
didn't
make.
hear you.
I think the same procedure as CPR would be applicable as to like check for danger
Exactly.
and then.
Good. Very good. Very good. So you need to apply the same principles as CPR, where you need to see if you are in danger or he's in danger. He is responsive or not responsive, right? You check if he's breathing. Yeah, well, that is all good, right? That is absolutely good. So you need to do those first few things, which I actually was discussing with you all a little while earlier, right? But if he's fitting, right, obviously sometimes he's fitting, his eyes are rolled upwards, you can feel a pulse. Obviously you don't have to worry, he's having a seizure moment, right? So you don't stop it, you let it go on, but make sure that he doesn't keep hitting his head, right? So what you do is, first thing first, you get everyone to stand clear, right? Everyone should move away from the patient, because that isn't, it's not safe, right? So first thing first, you get everyone to stand clear. Second, right, you ask someone around to time the seizure. So usually these kind of fitting movements, if they are less than 5 minutes, of less than 5 to 10 minutes, usually I say 5 minutes, less than 5 minutes, you don't have to worry too much, right? You can leisurely take the patient to the hospital, because these fits come and go. So if they last less than 5 minutes, great. But if they last more than 5 minutes, then yes, there is something to worry, right? And there are different types of fits, right? One can be called a generalized fit, another can be called a localized fit. If it's a generalized fit, right, you will see that the whole body is moving. And then there is something called a tonic seizure, a clonic seizure, and a tonic-clonic seizure. So all of these things you all don't know. But usually, the reason I ask you all to do number 3 is where you ask someone else to video the seizure, is because sometimes patients can confuse a fitting episode with something else, or cannot properly tell us what type of seizure it is. It can be a clonic seizure, it can be a tonic seizure, it can be a focal seizure, which is a localized seizure, or it can be a generalized seizure. So all of these things you all won't be able to tell, because when you bring this patient to hospital, at that time he is absolutely all right. He is not having any seizure movement. So how am I supposed to know what type of seizure he had, and how am I supposed to start the treatment? If I have the video with the person who was there with them, and they show me the video, they show the doctor the video, then we'll be able to understand what it is and we'll be able to treat it, right? Which is why the essential of taking a video of it, the essential of why you take the time I have told you, and why you make sure everyone else is standing away. It is safe for the patient and safe for you, right? So every time whenever I'm telling you anything, I'm giving you a logical reason. This is the same principle that needs to be applied whenever you are studying your other subjects, your medical subjects, that is medicine, biology, physics, chemistry. Try to understand it. Try to see, okay, as to why you need to do this, right? Because the moment you start doing this, the moment you start, thinking in that way, it's going to definitely help you when you go into medical school, right? Then as the guy is fitting, right, so you know that he is actually, you see in the first slide, right, you see there's a wicket there, right? So it might, with his hands, if his hands move, right, he will hit that wicket and it will hit him. So right, so you need to make sure that you need to move any potential harmful objects out of harm to prevent any injury to him, right? So that is with his with his arms or with his forehand. But if by any chance he's fitting, he's also going to be hitting his head, right? Because he's going to keep on hitting his head. So what you do is you can provide head support with whatever, so to prevent further head injury. So as you notice, he took out his waistcoat and he put it down, so that gives a little bit of support on the head, so that he doesn't keep hitting its head. Then you turn the patient in the left lateral decubitus position, also known as the recovery position, right? So usually the clear cut is where you need to put the, uh, after you've turned the patient on the left hand side, then you move the corresponding forearm on the top, and you basically flex the hip joint at 90 degrees, so that your thighs are touching the abdomen, right? So that's a classical one, but that is not essential. As long as you have turned the patient on the left lateral side, right, in this position, that's great. Now, I always told you that why on the left side, right? Let me explain that, right? Now it can be right side, left, why left side, right? That's the most important thing. Right. So this is because the common complication usually after this fitting episodes is aspiration pneumonia. What is aspiration pneumonia? It is when food, now this is the stomach, this is the lung pathway, right? Food, when the person is fitting, what prevents food? Now just generally tell me, what is the system that prevents food entering into the trachea? Generally, what prevents food from entering the trachea?
The glottis
Sphincter muscle.
area.
What muscle?
Sphincter muscle.
Which sphincter muscle? You mean the sphincter muscle inside the stomach, correct? No, I'm just saying generally there is something called something, I think one other person mentioned.
So glottis area, which is the epiglottis and the
Epiglottis, right? So epiglottis is a fold that basically acts like a valve. Whenever you're breathing, it opens up and it closes, right? So that is the importance of an epiglottis, right? So the epiglottis doesn't generally allow people to actually, food to enter the trachea, right? It doesn't allow that, because when it identifies, it doesn't allow anything other than air to enter into the trachea. But when a person is fitting, the epiglottis does not work. The sphincters are relaxed, right? So the sphincters are relaxed. So what happens? Food from the stomach. If, for example, he ate at around 11 o'clock in the morning, he had a nice, let's just say, a chicken kottu in the morning. I don't know, it's weird, but he had an early morning chicken kottu. At 11:30, he started playing cricket. And 11:35, he started fitting. So what's going to happen? Whatever he's eaten from the stomach, because the sphincters, that is, the lower esophageal sphincter gets relaxed, as someone else mentioned, it will move up. Food will be regurgitating. It will move in the opposite direction. And as the epiglottis is also not working, it will go into the trachea. And when it goes into trachea, it goes into the lungs. Usually the common lung that gets affected is the right side. Again, I will explain as to why the right side. And the patient can get pneumonia. Pneumonia is a lung infection, right? So this is the complication that is seen, that is basically seen in a person who is fitting. Now, what we can do by turning the patient in the left lateral side is of importance. Let me show you in the form of a, right? So this is the trachea. This is the trachea. Getting used to this, just hold on. Right. Okay. So you can see this is the trachea, right? This is the right bronchus. I'm just putting R. This is the left bronchus, right? So what can you see the differences between the right and the left bronchus? What about the diameter? What do you think? The diameter of the right bronchus and the left bronchus?
The diameter of the right bronchus is larger than the left one.
Very good, right? The diameter of the right bronchus is larger from the left bronchus, right? What about the angle? Can you see this angle and this angle? Right? In another way, you can put it, the right bronchus is straighter, whereas the left bronchus, there is a turn. Correct? Right? So the angle that is there between the trachea and the right bronchus is more as compared to the left bronchus, as in it is more straighter. So therefore, it is easy for food particles to go on the right side, which is why I told you that usually with aspiration pneumonia, whenever something gets aspirated, it is common to going in the right side of the lung, right? And the last one is it is shorter. You get the lung here, it is shorter, right? The right bronchus is shorter, whereas the left bronchus is longer. So one is the right bronchus is wider. Second, the right bronchus is more straighter with the alignment of the trachea. Third, the right bronchus is short, so it is very close to the heart. So because of these three reasons, it is very easy for food particles to going in the right side, but the left side it is quite difficult. So if you manage to turn the patient on the left lateral side, on the left side, what happens, because it is difficult for food to go through this area, right? And usually if you turn it on the left, the food will be in this direction, in this side. Can you see in this where I'm highlighting in blue? So because of that reason, right, it is unlikely for those food particles to go in the lungs and cause a lung infection later on, right? So that is why not the right side, but the left side. If you put the patient on the right side, you're just going to do way more worse, because you're basically allowing, giving them an open invitation. Come, come, come. All the food particles, you just can easily go to the right side. So it's basically, that is the importance of the left and the right. I hope you understand, right? Any questions so far? I'm assuming if there are no questions, people have understood, right? So what should you do? So you should, I've told you, you should move the person. Now, after this is happening, right, then you call 1990 for help or whatever, right? Apart from that, you should move the person from injury, removing any hazardous objects so that we took out the wickets. You can cushion the person's head. If he's an epileptic person, you can identify that, and when the paramedic comes in, tell them he's an epileptic person. I told you what epilepsy is. Epilepsy is a disease that is that causes convulsions, that causes seizures, right? You look at the amount of time, the duration of the time that the jerking or the fits last. You video it. You put the person in the recovery position once the jerking has stopped. If he's fitting, right, at that time you can't do anything about it, right? But if you can do it while. I always, when the person is fitting itself, it's a little difficult, but moving the person on the left lateral side is good. Don't move him too much, but just turn him on the left side. If you can't do that, once the fit has stopped, you can actually turn him on the left lateral side. Don't hold him, don't stop the fittings, don't give him, some people will say yakada kallak then the iron rod. When you hold it, the fitting stops. Though there is no science to any of that, right? So therefore, what's going to happen is you give a yakada kallak to hold, he will take the yakada kalla and hit you or hit himself, right? So do things which have a meaning or which have an essence to it, right? What don't you do? Don't try to restrain the person's movement. Don't let him, because he's jerking, he's fitting, don't stop that. Put anything in the person's mouth. Now this is a very classical thing I've seen. They like nane kama kala tibbe nෑ doctor hinda mama nikan යට kama dunna kama නැති hinda තමයි යට මේක වෙන්නේ. True, hypoglycemia can cause seizures, but what is this going to do? I told you all, the epiglottis and the sphincters are relaxed. The food is not going to go into the esophagus. The food is going to go in the trachea. You're basically putting food. You understand? So this is why that also has to be prevented, right? Don't try to move the person unless they're in danger. Don't go to unnecessarily move the patient. Give them anything to eat or drink until they're fully recovered, and don't try to bring them around, like in a sense, take them all around the place. No, let the fit this thing and let the paramedics do what they are supposed to do, right? So that was the end of seizures. Any questions so far? What do you do when you see a fitting a person? I'm assuming no question. Let's go into the next one. When someone is choking, what do you do? Right? When someone is choking, you ask them to cough. Right? If someone is choking, you ask them to cough. But if the person is unable to cough, right, there are two things that we can do. You can give 5 back blows. So you need to hit from the back, just from the back, right? And just give a 5 back blows in the direction of the airway. So you hold the hand from, like in the sense, your non-dominant hand from the front, right, anteriorly, and you hold him from the back and give 5 back blows. If that doesn't work, you can give 5 abdominal thrusts, which is called the Heimlich maneuver. You lock your fingers, right? You lock your fingers, hold him from the back, come at the tip, you know where the manibrum is, right? Not the manibrum, the xiphoid process, where the breastbone ends. From there, you need to just push upwards. You need to push upwards into the stomach upwards. You need to give 5 of those so that helps with choking. Why does choking happen? Because of an obstruction, right? So basically, what is it? When we are talking about the airway, to ensure the patency of the airway. If the airway is patent, right? If the airway is blocked, only the person will start choking. So that's the reason. That's the reason why we need to make sure that if there is something that you can't see, it might be deeper. So you can give the 5 back blows or the 5 abdominal thrusts, right? So this is the Heimlich maneuver. You can see how the person has held the hand, and you can actually automatically from the back, you can just push the thing upwards, or back blows, or this is the Heimlich maneuver, which is called abdominal thrust, right? So the first thing, again, you ask them to cough, because sometimes with cough itself it will come out. But if it doesn't come out, you can give the 2-5 back blows. You stay behind, you hit at the back of this thing 5 times, like just with the thumb, not with the thumb, with the heel of the hand. You hit it and then you push it upwards. Hit it, push it upwards, right? And if that doesn't work, you can actually give the abdominal thrust, right? And in the case that nothing of that works, then what we do is we just intubate the patient, right? We just basically give respiratory breaths, and we just put this thing. So we dislodge it more, and then later, after the patient has, because of the choking, if it's there for a long time, the patient can go into cardiac arrest, right? So then there is a reversible cause, and that reversible cause has to be treated. So that's how you treat a person who is choking, right? So if you find any of your friends anytime choking, what are you going to do? You basically will try to see if the patient is choking, the clear sign is they'll hold the neck as if they will feel like someone is squeezing their neck. That is why they hold the neck like that. I don't know if you noticed. Look, can you see? Look at the way he's holding. He's feeling like someone is actually holding his neck or squeezing his neck. That is the normal. It's like a sign. As soon as you see someone, you don't even need to talk. Obviously, he can't talk. The moment he does something like this, he's choking, right? That is the clear-cut signal that this guy is choking. He doesn't have to tell. The other person doesn't have to tell. Anyone who sees a person who does this, and you can see he's trying his level best to breathe, is a clear sign the person is choking, right? So if you can listen to you, if you can do this, you ask him to cough. You see if by coughing it is helping or not. If it's not helping, then as I told you, you need to give 5 back blows, right? If those 5 back blows don't work, you can give the 5 abdominal thrusts, which is also called the Heimlich maneuver. It is called Hemliech, the Heimlich maneuver, right? So you can see this person giving the Heimlich maneuver. Right. And if all of that fails, you can give 2 respiratory breaths and then wait for the paramedics to get there as soon as possible. If by any chance the patient goes into cardiac arrest, you start CPR. Nothing else to do. You can't read that, so you just make sure the heart is beating. You externally make sure the heart continues to beat. Any questions?
No, doctor.
No? All right. So as I told that I'll be only having an hour class. I'll stop there. Next week we'll be discussing about how we stop bleeding. And I think the best part, I think next week we'll be discussing is about, we'll be discussing about amputated arms, right? What you would do when someone's completely cut off. We'll discuss all of that next week. And next week we'll be discussing the new students. Speak to your counselors, right? The person who's spoken to you all. And there are a set of questions, right? Which I will actually, get. Can one student, let me just take a random student. Who was there last week? Is Zahara Ismail there? No, she's not there for the class. Is there anyone who was there last week? Any volunteers?
The Zahara is here.
Yeah. Okay. Zahara, can you do me a small favor? The questions that I gave last week, can you send it to me via? I mean, what you do is I'm sure you've written the questions down. No, take the photographs or whatever and send it to your counselor. Who's your counselor, Zahara?
Miss Sumaya.
Okay, send it to Miss Sumaya, and Miss Sumaya will send me those questions. And the new students, right, speak to your counselors and say that Dr. Burhan said that there were some questions that were given, right? And then I will send you those questions according to it, because I don't have to send it to everyone, but only the students who were not there for last week's class. Okay, so Zahra will do that until I get it from Sumaya. You speak to your counselors, and I will email it to all of your counselors. All right. So have a great weekend, because the weekend is still not over. Be safe. Wear a mask wherever you go. I'm sure you all do that. If you're in the Colombo area, don't unnecessarily go around because the number of cases are rising. Right. Do your part, and that is going to help everyone. All right. And I'll see you all next week. Take care.
Doctor,
Bye. Yes, go on.
doctor, I have a doubt.
Yes, go on, go on.
Now, suppose there was an accident, say
Yes.
a road accident, and
Yeah.
you call the relevant authorities and you perform CPR. But
Yes.
if the victim's ribs are broken or fractured, won't doing chest compressions even infect it more?
If you're saying if the if you're saying after the damage, so what if, let me understand your question. The patient was in a road traffic accident and he has hit his chest, right?
Yes,
And you're saying before carrying out CPR his ribs are already fractured. That is what you're saying,
yes,
correct? And
doctor.
then yeah, okay. So the thing is this, okay, you have to look at it, your Dwaragan, right?
Yes, sir.
Dwaragan, sometimes, when things like this have happened, right? This question was asked by another student also last week, but not with regard to the rib fractures. But if she was saying if by any chance the heart is already pierced because of a fragment, and then when you do CPR, is it going to damage it more? Now you have to look at the bigger picture. If the person has arrested, if his heart has stopped working, what is the most important thing? Yes, I understand his ribs are fractured, but I need to carry out chest compression. Somehow or the other, I need to carry out chest compression. So if you're experienced and if you realize that this person is having rib fractures already before you started CPR, you need to do it a little more diligently. That is a little more carefully, right? Not as strong as how you would do it, because if the ribs are fractured, it will be very easy for you to compress the chest, right? So
Yes,
don't
doctor.
do it too much. Okay, but if the ribs were not fractured, then you will understand there is some resistance. So you'll have to give more force. The force that you will give will be less if the person's ribs are already fractured. That is one. Second thing, if there are any fragments that are very sharp, and you think that when pressing it, it's going to hit on the heart, it might actually pierce the pericardium of the heart. Then correctly, as you said, Dwaragan, it is a risk for the patient. But
Yes,
at
doctor.
that time, you need to outweigh whether it is beneficial for this patient to carry out CPR or not. Because sometimes you will always have these things. Now we also go into a lot of conditions. I will talk to you all in these moments of this class. There are so many times where we have to make judgment calls, right? If you were there in my first class, where not first, yeah, first class, where I discussed about why medical checkups early are important. I told you about how we had to amputate a leg, right? We had to amputate a person's leg, right? Because the wound was very bad, and that wound was affecting the lung, was affecting in a systematic way, where it was going into the blood, and therefore the patient was becoming septic. And we decided that the best thing to do was to actually amputate the leg, right? We could have waited another day. We could have waited another 2 days. We don't know if we did. I mean, we can't tell if this person is going to survive in 1 2 days. We are not sure, because it's a very critical condition, right? And we did it. We thinking that we were saviors and we saved the life. So again, as I have told you that I'll be very honest with you all. My whole class is going to be it's going to be filled with honesty based on my experiences. I still remember I had a patient whose wound was very bad. Was very bad. He was finding it difficult to breathe. He had a lot of systemic problems as well, and we advised him that he needs to amputate his leg, so below knee amputation. He said no, I don't want to do this. Right? He kept on saying no, I don't want. I'd rather die. And we actually got a consent. But you won't believe it. He recovered. His leg recovered. He recovered. And then we did a skin graft on that area where we had, done some wound toilets. So just imagine if I had actually gone, not I, but we as a team had gone and actually amputated it. Can you understand? So sometimes in medicine, like as y'all are going to be medical students one day, there sometimes comes a point where you need to take judgment calls. Sometimes you know that by doing this, sometimes there can be a problem. But what is more important? Right? So we look at it in the point of view how we can make sure we can save this person's life. Right? So we look, there are other things that can be there, but we look at how can we preserve this person's life. And we decide, okay, I know he has a refractor, but we still have to carry out CPR. Understood, Warren? So this is something that is going to be there, not just with this. You're going to have more and more scenarios. So get this in your head. There's always going to be some problem, but you need to figure out a way to deal with those problems.
Yes,
Okay.
doctor. Thank you, doctor.
Any other questions? I'm assuming there are no questions. So just again, the new students, speak to your counselors and tell that there were some questions. Can we get it? I will make sure that I or Sumaya will actually send those questions over. Zahara, please send those images of the questions that I gave off to Sumaya, and I'll speak to Sumaya with regard to it. Okay, thank you very much. Have a great weekend. Take care. Bye.
Thank you, doctor.
Thank you,
Thank
doctor.
you.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.